All right, hi everybody. So last few slides that I promised I would post for you. So here we are. Let's. I'm just going to share my screen with you here so you can see exactly what I can see. And we only have a few last concepts to get through here. So this relates directly to what you're going to do in lab. And this is dealing with blood pressure. And we were talking as we left off there about blood distribution and how we can change these things during exercise to get blood where we need it and take it away from where we don't. We talked about the fact that we have central ways to do that, and also things like metabolites at the local level will also cause it to change, with the specific examples we gave being exercise. So let's continue on and just understand a little bit more about how blood is distributed through the body and why. So I want to give this example of a weird-looking man sleeping in his diaper. I'm not sure why that picture looks that way, but the point I want to get from this is that when we're laying down, like if we're sleeping on our back like this, then the distribution of pressure throughout the arterial system, as you can see, is pretty standard. It's pretty normal from the head to the 100 there that represents the level of the heart to the toes, which are just a little bit lower, but it's well distributed. If we look at the venous side, we see it's fairly evenly distributed as well. Not a huge difference, but there is a gradient, with 0 being at the heart and 20 at the head and feet. Thus, the pressure is higher and pushing towards the heart, which is exactly what we need for return to happen. So the driving pressure is quite low in this case, if roughly 15 to 20 millimeters of mercury, but that's really all we need. If we contrast that with what's going on in the standing body, then we see that there are some differences. So here I've drawn a line at the level of the right atria, and we select the right atria for a reason, because that's where the blood is going to be coming back into the heart. Okay. And if we consider where most of the blood is in the body, about 70% of it is going to be below the heart. That's an important point. So remember, we talked about this a little bit when we talked about space travel, for example, and how when we remove that orthostatic stress, everything changes. But for most of us, most of the time, we are on Earth, and when we're standing, gravity is going to pull that down. So yes, we've got the gravitational force, but we also just need to accept the fact that our hearts are not evenly placed in our bodies. They're up near the top. So what is the effect of gravity? Well, we call this a hydrostatic pressure, okay, because it's the weight on the water. And we can describe that by the equation. This is just physics of GPH. So G being the acceleration due to gravity, P being the density of the fluid. And that does change a little bit with our blood, but for the purpose of this discussion, we'll talk about it being fairly constant. And H being the height of an uninterrupted tube. So at what level is the gravity actually pulling on that? So if we look across the body in the arterial side, we can see that there are differences. So whether we're talking the level of the heart, the level of the feet, or the level of the head, there's a gradient that exists. We can subdivide that into what we'll call active pressure, and then the pressure driven by the hydrostatic pressure. Okay, so we can see that there's really a difference there. So where do we come up with the 200 at the feet, for example? Well, we see that there's 100 millimeters of mercury of that pressure is driven from the heart pumping. It's creating a force. But the other half of that, the other 100, is actually sort of the weight of gravity pulling down on that blood through an uninterrupted tube. Okay, we can see that it's 0 at the heart because it doesn't have any uninterrupted tube to pull on, if you will, and it's much lower at the head. Okay, which makes sense. So below this line, as I just kind of alluded to, gravity is working to pull blood down, okay, on the arterial side, it's pulling it away from the heart. And above the line, it's the arterial side is pushing against that. So it's like a negative. That's why when we look over on the right-hand side, I don't know if you can see my mouse, but I hope you can. Over here, the active pressure is 100 because that's where the heart is pumping at, but it's like a negative 40 because the arterial side is pushing up towards the head. Thus, we end up with 60, okay? Whereas down here below that, they're additive. So subtract 1, add 1 down here. If we look over on the venous side, okay, it's slightly different. So again, the pressure, there's an active pressure that's sort of a carryover, if you will, from the arterial side that's pushing through on the venous side. So 20 down in the feet, but it's 0 at the level of the heart, okay? But down here, the pressure from gravity pulling on the blood is still the same. It's 100. So the net effect would be zero cardiac blood filling if this happened in isolation. Right? Because right now what we're saying is the weight of gravity pulling down on the blood in the venous side is 100, which is much higher than the active pressure pushing it back towards the heart, which is 20. So in the absence of any other factors, we would have a problem. Blood would never make it back to the heart and thus be pumped back up to the head. So how do we actually have venous return? Hopefully you're already starting to figure this out because we have talked about it a little bit. But a lot of it has to do with these venous valves. Okay, so we've already talked about the skeletal muscle pump and how when we squeeze these things, the blood can only be forced one way, which is up, because the doors slam behind it. But the other thing that these do is the valves actually break up the height. So we talked about the GPH with the H being a continuous tube. But if we put stops in that tube, so you can see here on the left, these are open valves as systole is happening and blood is pushing through. But say during diastole, even though it's not that pulsatile on the venous side, or any other situation when these close, then we don't have a continuous tube going from the top to the bottom. We have these tiny little tubes, and each one is acted on by the height between valves rather than the whole length of the leg or all the way up to the heart. On the right here, you can see that's actually just an ultrasound image of what it actually looks like with the valve closed. So essentially, these venous valves function to decrease the height. Okay, we talked a little bit about varicose veins. I could tell from the looks on some people's face they didn't know what I was talking about. But varicose veins here on the right, you can see they can manifest as sort of like something they call spider veins, where they turn blue and come to the surface and you can see them, or it can be kind of bubbly under the skin like this. And you can sort of see how that happens here on the left. We can see the far left, we have blood flowing to heart. That's a normal one. Right beside that, the second one over, we can see, well, that's what would happen when the valve closes normally. And on the far right here, we can see, well, what happens when that valve doesn't close, or sometimes it may fold in on itself. Then what we have is this problem where we have extra pressure on the one below it, because now suddenly the column got twice as big. And if that one fails too, then the column gets even bigger as each valve fails, and thus it starts to bulge because the pressure goes up. So as we said here, the distended vein increases hydrostatic pressure and decreases the venous return. Thus it's hanging out in the vein, and the vein starts to pop. So it raises another question about the effects of gravity and what's going on here in this weird thing that looks like some kind of a Ferro ride. This is what we call a tilt table. And a tilt table allows us to test the effects of gravity on the cardiovascular system without having people engage their muscle or have sympathetic drive. So essentially, before this picture was taken, that woman was lying on that table on her back, and then they just take this big wheel and they turn her up. So she didn't have to engage any muscle mass. She didn't have sympathetic drive. We can purely see what happens when we change gravity around her. And so let's look at what happens. So looking at this graph, okay, you can see we're representing each of the variables down here. So starting at the top, we have arterial blood pressure, then we have mean atrial pressure, Q, stroke volume, central blood volume, heart rate, and so on and so on. And we're looking at peripheral blood flow and blood flow to the gut. What's represented in the first column here before the line is what happens to these variables when somebody's been laying for a prolonged period of time. Okay, so laying on their back, not doing anything. Then we show in the middle column there what happens immediately upon putting somebody up. And then this is being up for a little while, and the body has time to adapt. So we can see here, arterial pressure, you can see systolic at the top, diastolic, that's why the range. And we see that when we tip somebody up, then we have these changes. So systolic pressure drops, diastolic stays pretty constant, might go up a little bit, okay? And that is going to be that way until it's stabilized. When the person's been staying for a while, then we're going to see systolic pressure go way up, it overshoots a little bit, and then kind of comes back down to where it should be, okay? What's going on with right atrial mean pressure? Well, we can see that mean pressure drops right off when we take somebody and put them up until, again, it normalizes. At the same time, cardiac output goes down. So that suggests we're not getting blood back to the heart. Thus, the heart is not able to pump out as much as it wants to because the blood is going somewhere else. And really, this is probably a result of venous return. And we can see that if we go down to the next one, which is stroke volume, that does indeed suggest exactly what's going on. So we take somebody that's lying down, their stroke volume is about 100, a little bit higher than we'd expect. We'd say typically, 75 for a normal person. And part of that is just going to be because they're laying down. It's easy to get blood back to the heart when they're laying. We stand them up, all the blood pools in the legs, and we see stroke volume falls right off. And in this case, it almost gets cut in half until they come back and they normalize. It comes back to 100, and you can see it's starting to slope back down towards normal beyond that. So that really is what's driving central blood volume. You see the same pattern in that one below. And it shouldn't be surprising at this point that we see heart rate is low when they're laying at rest, okay? And then as soon as we take them and we stand them up, well, then we see it was low because stroke volume was high because it was easy to get blood back when you're laying down. As soon as we stand them up, we see heart rate goes way up because stroke volume goes way down. So cardiac output went down a little bit, but it would have dropped off precipitously if the heart rate hadn't adjusted to sort of bring it back in, because it's saying, hey, I'm not pumping as much per beat. I'm going to have to beat a little bit faster. Okay. I'm not so concerned about the forearm blood flow and the splenic blood flow, but you can see the patterns here, which are very similar as well. So again, all of this kind of just points to the fact that we are starting to see blood pool when we stand them up, because the body has to adapt and has to make those adaptations, which are going to allow blood to come back to the heart. So we need to deal with venous constriction. We need to redirect that blood so it comes back, venous return goes up, stroke volume goes up, cardiac output's there. So what application does this have in sort of a clinical sense? Well, we need to think about then, how would you counsel a patient that may have venous insufficiency, or they may have heart failure, they may have any other vascular disease? Well, if they've been laying all night, how are you going to tell them to get up in the morning based on what we see here? This is kind of a funny picture where we see a lot of people posing with these astronauts. That's a famous Canadian astronaut, Chris Hadfield, on the left. And what I want to point out is that all of these astronauts and cosmonauts who have just gotten off of the space shuttle are they're all laying down. And a few things going on here. One, they can't stand up because they've been in a state where they did not have to deal with the effects of gravity for quite a long time. And their body is just freaking out. They actually, if they tried to stand up, they would probably just pass right out, because the effect of stroke volume dropping and their heart trying to catch up and everything, cardiac output would fall right off. You also see that they're wearing blankets because they're probably having a hard time thermoregulating as well. So what else do we know from nature? Well, we talked about why we see these differences in pressure because of the hydrostatic pressure in man. Well, what do we see in other animals? In some ways, despite some of the things I've pointed out about dogs not being able to sweat and how they pant, well, they might be better designed cardiovascular, because 70% of their blood is above their heart, whereas 70% of ours is below. So that's an advantage from a cardiovascular point of view, and that it's easy to get blood back to the heart. So we work very hard to get blood back to the heart. And so the pumping gradients are totally different. And certainly we can think of other examples of animals where it's even more exaggerated, but they're actually fairly well designed as well. Because if you look at where a giraffe's heart is, it's kind of right in the middle. So really the same processes apply and the same factors are acting. It's just that they're magnified when you have a super long neck and a tiny little head up at the top and these really long legs. And so same thing on the venous side is really all I wanted to get across. Okay, so let's finish by talking about what's going to happen in lab. So in lab, you're going to assess blood pressure in the arm and the leg, so using the posterior tibial artery, okay? And you're going to get an ankle brachial index, okay? So you're going to look at the difference between the foot and arm pressure. And we're going to add some perturbations in this. You can check out this video if you want. We're going to have perturbations where we take you or the person in your group and we're going to lay you down head down, and we're going to put you head up. And we're going to look at what are the differences and how does the body respond to these challenges. Obviously, if we put our head down, it's easier to get blood from the feet back towards the heart, versus if we go head up, and we're going to do this after exercise, then we can see how does it aid or how does it hinder that happening. If we take this to sort of an easy to understand example, I think most people, if you think about somebody who's not feeling well, what do? You lay them down, you put their feet up. Why do you do that? Well, let's try and get blood back to their heart and thus to their head, and oftentimes that will help people feel a lot better. So in lab, we're going to be exercising, as I said. We're going to be measuring blood pressure during that, and then we'll be measuring blood pressure after exercise. So immediately after, so 10 seconds, 30 seconds, 60 seconds after, and then we'll be laying down head up or head down. One of the keys here, I say note, during lab, you're going to try not to use your leg muscles for balance. And why are we not going to do that? Because as we talked about before, by engaging the leg muscles, we're actually helping return blood flow to the heart because we're using that skeletal muscle pump. And that's really where it's most effective, is in the legs, obviously. We also need to be careful. As a note of caution, don't let your participant fall off the bike, particularly if people are lightheaded. Okay, so a few take-home points here. Gravity absolutely has a pronounced effect on blood pressure control. Space travel and stuff are pretty neat ways to look at this, but even just the effects of changing posture on Earth can affect it. Venous valves are absolutely required. They're not just a neat thing that works with the skeletal muscle pump. We actually couldn't have circulation without them when we're in the upright position. And we did talk a little bit before about this idea that we can change some of these things externally as well, whether it be through compressive socks or stockings, or any of those other things that we talked about, where we might be able to actually increase transmural pressure and push the blood back up. And again, we're relying on those valves to make that happen. So with that, I will remind you that Monday we're doing our review. If you have questions, specific questions about this material or anything else, please shoot me an email and I'll have something prepared. Otherwise, you can come to class and we will go on the fly. All right, we'll see you then.